So thyroid dysfunction is quite common during pregnancy. So in women of reproductive age, for example, TPO antibody positivity occurs in roughly 10%. And during pregnancy, subclinical hypothyroidism has a prevalence of about 3.5%. And the recent ATA guidelines published in Thyroid in 2017 have very clear treatment recommendations when it comes to the combination of TPO antibody positivity and the combination with TSH concentrations. And one of these recommendations is, for example, for TPO antibody negative women, that treatment is recommended for women that have a TSH above 10. But there's also this gray area of women that have a TSH level that is between 4 or the upper limit of your institutional reference range to 10. And in this gray area for TPO antibody negative women, it can actually be quite difficult to make a decision of whether or not you're going to treat the patient that's sitting in front of you. Now, the same sort of gray area can also be extracted from the guidelines for TPO antibody positive women. However, the TSH ranges slightly differ there for TPO antibody negative women. So for TPO antibody positive women, treatment is actually recommended if the TSH is above the institutional reference range or above 4 milliunits per liter, whereas the gray area where treatment is not recommended but can be considered is the TSH range between 2.5 and 4 or 2.5 to your institutional reference range, upper limit of TSH. And when you have a patient sitting in front of you who is in this sort of gray area for these treatment recommendations, there's a few tricks that you can use to think about whether or not this patient can actually benefit from treatment. So what I usually do in clinical practice is take a good look at the patient's history. So certain adverse pregnancy outcomes have been associated with thyroid dysfunction, particularly TPO antibody positivity and a high TSH. And those are mainly miscarriage and preterm birth. So if a woman would be in the gray area and already have a medical history of preterm birth or miscarriage, that would definitely be an additional argument to treat these women if they're in the gray area for these treatment recommendations. Another thing is that we know that thyroid physiology undergoes major changes during pregnancy. So typically we know that the TSH concentrations should decrease during pregnancy because of HCG stimulation that peaks around the 10th to 12th week of pregnancy. And especially the end of the first trimester is therefore of relevance if you want to decide whether or not you're going to treat a woman that's in this gray area. Because if the TSH is in the gray area, is in the 2.5 to 4 millunit per liter range for the TPO antibody positive women, or is above 4 for the TPO antibody negative women, at the 12th week of pregnancy, when you would actually expect the TSH to be lower because of HCG stimulation, then that is actually different than if the woman would present to you in the gray zone with her TSH or TPO antibody status while being at the 6th week of pregnancy, or for example, the 20th week of pregnancy when HCG stimulation is less relevant. So also there, you can have additional arguments for whether or not you would want to treat a woman. Because if she doesn't respond well to HCG and suppress her TSH, that's probably also a sign of changes in thyroid physiology because of TPO antibody positivity, for example. One other factor that can also aid you in clinical decision-making in the women in this gray area is, for example, the height of the TSH. So recent small randomized controlled trials from the group of Faridun Azizi in Iran have actually shown that the positive effects of levothyroxine on, for example, preterm birth do not occur for TSH concentrations below 4 milliunits per liter. And this is actually the case for both TPO antibody positive and TPO antibody negative women. So if a woman that's TPO antibody positive and is in the gray zone has a TSH of just above that limit for the gray zone, for example, 2.6, that is also very different than if this woman would have a TSH that's 3.9, which is of course the upper side of the gray zone. So also there you can use the small differences to think about whether or not you would want to treat this woman with levothyroxine. In conclusion, There's probably three things that you can think about when trying to decide whether or not you want to treat a woman that falls within the gray zone of TSH concentrations and TPO antibody status according to the recent ATA guidelines. The first of all being the gestational age at presentation. That's based on thyroid physiology and HCG stimulation. The second one being the actual TSH concentration, because obviously a higher TSH concentration within that gray area would be another reason to think about treatment. And the final thing that you can definitely also think about when deciding whether or not to treat women in this gray area is the past medical history. Particularly a past medical history of miscarriage or preterm birth could be an additional reason for considering levothyroxine treatment in women, again, within that gray area of the ATA guideline treatment recommendations.